All right, so I think we will get started while we're waiting for a few others to join, because we're bang on 12:01 at the moment. So welcome everyone to our chronic disease management webinar. My name is Jamie and I'm a primary health trainer here at WAFA. And before we begin, I would just like to do an acknowledgement of country and acknowledge and pay respect to the traditional owners and elders of the land that we are meeting on today, recognizing their diversity and the significant importance of their cultural heritage, values, beliefs, and self-determination in contributing to the positive health and well-being of the whole community. Just a quick disclaimer as well, this webinar will be recorded so that we can also distribute it after. So if you could keep your cameras off as well as your mics off or muted, that'd be great. Up until we get to our questions segment at the end, where you're more than welcome to either pop questions in the chat or raise your hand and we can answer any questions that you've got then. Just one more thing to note, since we live in a different day and age now of AI transcription software, just want to put a disclaimer out that any AI transcription software is not permitted in this webinar and will be removed by the facilitators for privacy reasons. So today speakers are WAFA's quality improvement team. We've got Chloe, who oversees Northwest as a QI coach, Connie, who oversees Southeast, Cass, who oversees the Southwest, and Cara, who oversees the Central area as well. So they will be our speakers for today. And I would like to invite Cass to kick us off.
Good afternoon, everyone, and welcome to the Quality Improvement Team's first quarterly webinar event. Today's topic will be discussing chronic disease management. Before we begin, I would like to address that we are aware that there are some upcoming changes to the terminology where the phrase chronic disease management will be changed to chronic condition management. But for the purpose of this presentation, we'll be using the term chronic disease management. And that brings us to today's speakers, who I'm sure some of you would have met during your QI practice visit. My name's Cassie. I'm the Quality Improvement Coach for Perth Metropolitan Southwest. I've been a registered nurse for 9 years and primarily worked in primary healthcare as a practice nurse, nurse manager or practice manager, and I've also worked in aged care as a clinical care coordinator. Connie.
Hi, my name's Connie. I'm a Quality Improvement Coach for Perth Metropolitan Southeast. I've been a registered nurse for about 13 years.
I'll listen to yours.
And I've worked in a few areas of primary healthcare, such as rural general practice in New Zealand. I've been a practice nurse, a clinical lead nurse, and I've worked across general practice, urgent care, and women's health. And Chloe.
Hello, I'm Chloe. I'm the Quality Improvement Coach for Perth Metropolitan Northwest. I've worked in a wide variety of healthcare roles, starting out on reception, working as a practice nurse, and in healthcare management. I'm most passionate about primary healthcare, which I see as the area in which we can make the most difference to people's everyday lives and the prevention of disease. I'll pop you over to Cara.
Good afternoon, everyone. I'm Cara Thomas. I'm the Perth Central Metropolitan Quality Improvement Coach. My background is in health promotion and training. I was an asthma educator for 4 years, where I supported patients, community, and health professionals in managing respiratory care. For the past 8 years, I've worked closely with primary healthcare teams across chronic disease management and quality improvement. I'm passionate about patient-centred care and committed to advancing strategies that empower individuals and healthcare providers to achieve better health outcomes. And now I would like to pass on to our first speaker today, and that is Connie.
Okay, so here we have the learning outcomes for today's session. So we're aiming to provide you with an understanding of the fundamentals of chronic disease management, along with the roles and responsibilities of practice staff. We'll discuss the steps involved in creating comprehensive personalised care plans for patients. We'll look at some of the tools used for implementing evidence-based practices into daily clinical routines. You will gain an understanding of how you can utilise technology and data to enhance your patient outcomes. We'll also take a look at the strategies to collaborate with multidisciplinary teams for holistic care. So first, let's start by taking a look at quality improvement. So quality improvement, or QI, is the process of regularly reviewing and refining your practice's systems, structures, and clinical care. Some of the benefits of doing QI are the improvement of patient outcomes, experiences of care, practice systems, and improved provider and staff satisfaction. QI activities are a mandatory requirement for practices who want to be accredited against the RACGP standards and to be receiving the PIP-QI payments. Most of us are already doing quality improvement, often without even realising. The key is to always document your QI activities so systems and processes can be reviewed and then changes can be made if necessary. Okay, so chronic disease management can provide us with so many potential quality improvement activities, especially when we tie it back to the fundamentals or the purpose of QI. So for example, if you're going to look at improving your practice systems and efficiencies, you could review the current processes and procedures in place and then test a change idea to determine if this should be adopted into your practice's CDM process. Or if you want to improve provider and staff satisfaction, you could focus on increasing attendance to education sessions on chronic disease management, like this one, to improve your knowledge and skills. You could use technology to streamline workflows, or you can focus on fostering a supportive team environment with clear communication, holding regular team meetings, and where you can celebrate any small wins. If your practice would like to focus on improving patient outcomes, then there's the opportunity to undertake an activity identifying patients who are eligible for a chronic disease management plan, and then appointments can be made for these patients to discuss management options and enhance care. Or maybe it can be as simple as looking at ways to increase the number of CDM reviews amongst those with a current CDM plan to provide a high level of care to those patients. All of these QI activities can be documented in a PDSA, or a Plan Do Study Act, along with the Quality Improvement Register, which you'll see the examples for on the screen. Obviously, if you need any support during any stage of your quality improvement quest, our team of QI coaches are here to help you. We can work with you to identify where to begin, provide education on how to interpret your practice data, and support with the documentation of any activity. So now let's take a look at the benefits of chronic disease management, or CDM plans. As you'll likely be aware, Medicare Chronic Disease Management Plan is a structured approach developed by a general practitioner to coordinate care for patients with chronic medical conditions. These conditions are defined as being present for 6 months or longer. The plan may include a GPMP, also known as a General Practitioner Management Plan, and a team care arrangement which aims to provide organised and collaborative care with allied health services. There's so many benefits to a chronic disease management plan, particularly to the patients, such as better health outcomes, increased satisfaction with care, and a person-centred care approach. CDM services help manage and coordinate care for patients, reducing the risk of acute exacerbation and functional decline. Additionally, patients can benefit from reduced healthcare expenses due to fewer unnecessary hospital or emergency department visits. There's also so many benefits to the practice who are providing chronic disease management. There is the opportunity to deliver coordinated, multidisciplinary care to patients, which improves their health outcomes and satisfaction with care. Practices can bill for CDM services provided to patients with multiple chronic conditions, which helps in managing and coordinating care for your eligible patients. Practices can strengthen therapeutic relationships by registering their patients with chronic diseases for My Medicare and then scheduling them for regular reviews. This approach helps in maintaining continuity of care and ensures that patients are consistently monitored and managed. So next up, Cassie will discuss the roles and responsibility of your practice team, give guidance on how technology can be utilised, and also give you an overview of the commonly used MBF item numbers for chronic disease management.
Involving all practice staff in the chronic disease management process is crucial because it ensures comprehensive care, it improves patient outcomes, and fosters a collaborative environment where each team member's skills and roles contribute to the overall health and well-being of the patients. Here I discuss the potential ways each team member can play a role in chronic disease management. Firstly, the practice nurse. Now, I might be a little bit biased about the importance of nurses as I am a nurse myself, but I think nurses play a pivotal role in the management of chronic disease in general practice. When the patient has an appointment with a practice nurse, the nurse can be utilised to conduct a patient assessment, identify patient needs, identify the personal impacts that chronic disease has had on the patient's activities of daily living or lifestyle, draft the chronic disease management plan using patient-centered goals, provide patient education on how to manage their chronic disease, promoting self-management strategies for the patient, and offer ongoing support to enhance the patient engagement in their own healthcare journey. Another key responsibility can include running quality improvement activities, using practice software to identify patients who are eligible for the chronic disease management plans, and in implementing a recall system for the patient to attend the clinic when the patient is due. Nurses can also play an important role in driving health promotion and prevention through health assessments, immunisations, and providing patients with resources. The nurse can also be responsible for follow-up appointments with the patient to discuss chronic disease management plans and support, with a focus on meeting the goals outlined in the chronic disease management plan. The GPs. The GPs play a role as the primary coordinator of the patient's care. Their responsibilities include comprehensive assessment and diagnosis of the chronic disease, the documentation of the chronic disease in the practice software, ensuring to use correct coding to maintain precise records for data-led initiatives, comprehensive clinical chronic disease management by providing recommendations of pharmaceutical products and referrals to other chronic disease management services and allied health, development, completion, and billing of the chronic disease management plan itself, coordinating care between the healthcare team to ensure ongoing monitoring support of the chronic disease for the patient, and collaborating with specialists and allied health for consistent, comprehensive, best patient outcomes. The admin team. The admin team are usually the first point of contact for patients. They communicate with the patient via phone calls, SMS, or face-to-face when the patient comes in for an appointment. The admin team are responsible for booking patients correctly, ensuring there is enough time allocated for the nurses and the GPs to perform a chronic disease management plan. Admin are often the first point of education for the patient, explaining why they've received the recall, explaining what a chronic disease management plan is, along with explaining to the patients what their appointment might entail. Admin also can have a key responsibility in establishing and overseeing a recall and reminder system. Other in-house allied health team members, such as a non-dispensing pharmacist and a nurse practitioner, can also play a crucial role in developing comprehensive chronic disease management plans. For example, a nurse practitioner can prescribe and diagnose, whilst a non-dispensing pharmacist can provide a comprehensive medication review and make necessary changes. These roles are invaluable in reducing the workload that would otherwise fall on a GP, ensuring for a more efficient and effective healthcare delivery. So now we have a process map that you can choose to implement at your practice. This is used to work alongside a quality improvement activity of improving the identification and management of patients with chronic disease. This is only a suggested pathway that you could use within your practice, and we are aware that this may not be the best suitable pathway for your team. If you would like a full copy of this process map or to have this tailored to your practice's needs, you can request it from your quality improvement coach in your area. Today, we will be discussing only the top row of this process map, which is the identification of patients eligible for chronic disease management plan. So the first point, highlighted in red, is identifying the patient that has the potential to be eligible. This can be done when the patient presents at front desk to check in for a standard appointment, or when the patient calls reception regarding a chronic condition, a referral to allied health, or asking about a chronic disease management plan, or can be done using your clinical software or a data extraction tool such as Primary Sense. The next step, highlighted in the first yellow diamond, is checking eligibility for the service. Is this patient eligible for a chronic disease management plan? Is this a regular patient? And do they have a chronic disease condition? The next step across is checking if they're eligible for billing. When was their last chronic disease management plan billed? If it was over 12 months ago, they are eligible. See if it is available for the nurse or doctor to either discuss or have completed today. If you have checked PROTA or My Health Record and the chronic disease management plan was billed at another practice, and this is a regular patient to your practice, you could ask the patient if they want to continue their chronic disease management plans at your practice moving forward. If yes, ask the patient to complete a transfer of medical records form for the chronic disease management plan. So now moving down and across, what if the chronic disease management plan was billed at your practice less than 12 months ago? What can we provide for this patient? So, are they eligible for a chronic disease management plan review? Or could they see a nurse for a 10997? And then finally, highlighted in green, what if the patient has completed all eligible services? It is crucial to check and add reminders for when they are due again. This ensures the patient can continue to receive timely care and follow-up services, which are essential for managing chronic conditions effectively. Sorry, just back to the other slide. This demonstrates how incorporating additional screening for eligibility steps from the very first point of contact with patients can enhance the level of care provided. Compared to a standard appointment, this proactive approach shows that shows patients that your team is dedicated to monitoring and supporting their chronic conditions effectively. So technology. Now, one of the ways I mentioned identifying patients is utilizing clinical software or a data extraction tool to identify patients. Primary Sense is an excellent tool to be utilized when identifying patients for chronic disease management. One of the reports our team recommends is the patient complexity reports. There is two versions of these reports, patients with moderate complexity level 3 and patients with high complexity level 5 and 4. The complexity levels of patients in these reports are calculated with the Johns Hopkins ACG tool, which is an evidence-based tool of over 30 years that indicates the likelihood of hospitalization and risk of poor health outcomes. A level 1 indicates a very low level of complexity with no known risks for poor health outcomes, whilst a level 5 is the highest complexity, where a patient in this level typically has significant multimorbidities and polypharmacy and are at greatest risk of poor health outcomes. On the screen, I've provided a snippet of each of these complexity reports using demo patient data. The difference between these two reports, other than the complexity range, is the moderate complexity report displays total numbers of chronic conditions and mental health conditions, whilst the high complexity report displays total amount of medications in their last medication review billed in your clinical software. Both of these reports show a grid containing multiple columns which can be filtered using the arrow keys next to each columns. The columns contain the following information: the patient age, if the patient has identified as Aboriginal or Torres Strait Islander, the hospitalisation risk, their medical information, and what MBS items they have or have not been billed in your clinical software. Remember, the displayed information is based solely on your data, so always double check MBS eligibility with PROTA to ensure accuracy. My favorite feature is the existing appointment column. This can be filtered to display those of the most recent upcoming appointments first, allowing you to identify and target patients that already have appointments and could benefit from additional chronic disease management services today. So other than those cool features I just showed you, why should you use this report? Using the complexity report allows for the prioritization of patients with advanced complex diseases and needs. This approach is more effective compared to running a report of all patients' missing billing items. By focusing on patients with higher complexity, healthcare providers can ensure that those who require the most attention and resources receive timely and appropriate care. This targeted strategy not only improves patient outcomes, but also optimizes the use of healthcare resources, leading to a more efficient and effective healthcare delivery system. So what if you don't have Primary Sense? Well, if you're interested in having Primary Sense installed, please contact your QI coach in your area. But if not, there is also other options. You can utilize your clinical software, the heart of where all your patient information is installed. Now, there is a lot of practices in WA and there is a lot of different clinical software available, and I'm unable to list and go through them, each one of them today. But one example I have is the database search feature in Best Practice that allows you to create and run custom SQL queries to identify specific patients and displays the name of the patients in list format. From here, you can bulk add reminders or create a recall list for phone calls. If you're needing assistance with identifying data in your clinical software, this is something your QI team can help you with. On this slide, we show the MBS items that can be utilised for chronic disease management. The most frequently used items are the 721, the 723, and the 732s. But there is also chronic disease management item numbers for video consultations, and there is additional versions of these numbers for non-VR GPs. We have also listed on the slide the minimum claiming periods for each item. It is important to educate all staff about the MBS minimum claiming periods, especially those staff involved in billing and identifying eligible patients for recalling to prevent items being rejected by Medicare. It is also useful to know when setting up standard reminder frequency. Ensuring the patients are being recalled and booked at a consistent time frame will not only prevent MBS rejecting, but will also establish a healthy routine with the patients, where the patient will become familiar on when they should be proactively booking in to see the doctor. Now, a service I mentioned earlier under nurses' roles is a nurse can be responsible for the follow-up appointments regarding chronic disease management and support. This is often an underutilized nurse-led MBS item known as a 10997. It is eligible 5 times a calendar year and can be used to monitor progress towards the goals of the chronic disease management plan. This allows for more frequent reviews compared to using a standalone GP item, ensuring better tracking and management of the patient's condition. The information and links within this table are sourced from the Medicare Services Australia page. It is always recommended to review MBS items and any updates via the Medicare Services Australia website before billing. I also recommend always clicking on the extended notes of each MBS item, as this is often where you'll find information regarding the compulsory requirements for those billing items. Upcoming changes to the MBS chronic disease management arrangements. Unfortunately, we don't have any updates regarding this other than those that are posted to the public on the Department of Health website. It is still pending legislation. They finished their sitting days mid-February, so we are waiting for confirmation if it has passed or not. What we do know is the proposed date is occurring will be July 1st, 2025. The plan is to replace the current GP management plan and team care arrangement with a single GP chronic condition management plan item. It will be requiring patients to register for My Medicare to access management plans. However, it also does mention patients who aren't registered will still be able to access management plans through their usual GP. The specific details regarding this hasn't been disclosed. The changes will encourage management plan reviews by equalising the fees for developing and reviewing plans. It will be requiring patients to have their plan established or reviewed in the last 18 months so they can retain access to allied health and other services. The link regarding this information will be available on the slide deck after this presentation. And next up is Chloe to discuss case studies, documentation, and case conferences.
Thank you, Cass. So this first slide here is a little bit of a case study looking at a potential patient flow where current MBS chronic disease management item numbers are used to their advantage over a 12-month period in creating a truly comprehensive service for the patient. This example does assume that all eligibility criteria are met for a patient with a chronic disease, residing in the community, seeing their usual GP, and the usual checks have been done that it was not provided elsewhere and the patient consents. So visit number 1 is the one where the GP management plan and a team care arrangement are prepared. On this visit, a 721 and a 723 could be billed, plus or minus any bulk billing incentive the patient will be eligible for. If this patient has now been identified as having a chronic condition, they may be eligible to be discussed at a case conference, with the MBS items available for this being based on whether the GP arranges or participates in it and the length of time taken for the conference. We'll follow with more on case conferencing shortly. Visit number 2 could occur 3 months after the first visit, and the patient could also be scheduled for a health assessment if eligible. At this time, the GP management plan and TCA, team care arrangement, could be reviewed, and one of the education sessions previously identified in the goals of the chronic disease management plan could take place with a nurse. This means that on this day, items 732 and 732, which can be billed twice on the same day, one for review of the GP management plan and another for review of the team care arrangement. 705 or 707, which are time-tiered items for the health assessment. 10997, plus any bulk billing incentives could be billed. That patient could then return for visit number 3, 3 months later, for further review of the GP management plan and team care arrangement. At this stage, they could be referred for a home medication management review and have another service with the practice nurse to check in on goals and healthcare education, meaning that for this visit, items 732, 732, 900, 10997, plus any eligible bulk billing incentives could be billed. This next visit is just an example which could really come at any point in the patient's yearly journey. But in this instance, we're assuming that for simplicity, the patient's conditions are beautifully controlled, repeat prescriptions are dealt with at the routine appointments so that this patient hasn't had any additional appointments. This, in reality, is unlikely, and none of the review appointments preclude additional appointments being made or billed for any acute presentations, except for on the same day as the care planning appointments. In the instance of this case study, this is simply a seasonal attendance for an influenza vaccine, as per the goal setting in the care plan, and a 23 and a 10997, plus eligible bulk billing incentive numbers can be billed. Patient visit number 5 in this example should come at 9 months after the initial preparation of the GP management plan for a chronic disease management review and further session with the nurse, meaning that 732, 732, 10997 plus or minus any bulk billing incentives can be billed again. At 12 months after the initial chronic disease management plan preparation, the process can basically begin again. Data shared with WAFA suggests that over the last 12 months, 56% of patients attending GP appointments in WA had at least one chronic condition. By optimising their treatment using the tools we have available under the MBS, we're providing truly comprehensive patient-centred care, which is consistently demonstrating improved patient outcomes, lower rates of hospitalisation, and increased health education. Another way of analysing the benefits of implementing this into practice is looking at it in terms of how it will contribute to sustainability of the business. In just this example alone, assuming all services are bulk billed, with no bulk billing incentive eligibility, and using the lowest option of the time-tiered items, this patient flow and item number utilisation will provide an income of $1,128.05. In reality, this patient is also likely to attend for other appointments within the 1-year period. Case conferences can be done more frequently. They can be done every 3 months, not just once per year. And the patient may take longer than the shortest time-tiered item numbers and are quite likely to be eligible for bulk billing incentives. As always, we would always recommend referring to MBS Online for the most up-to-date information. This next slide's looking at documentation within our chronic disease management plan. We all know how important documentation is. So let's have a look at what specific documentation we need to create quality GP management plans and team care arrangements. Firstly, current best practice, and we know that this will be an inclusion in the pending Medicare changes to chronic disease management, is that patients obtaining GP management plans should do so from their regular GP and should be registered with that practice on My Medicare. We would strongly encourage practices to be looking now at incorporating My Medicare registration into their daily workflow and are very happy to provide assistance with establishing and reviewing these processes. Please do reach out if any help's needed. Back to the slide. Medicare have identified these documentation points as a non-negotiable in creating a GP management plan. However, there is plenty more that we can elaborate on to create a truly patient-centred, personalised chronic disease management plan. The first point that must be documented is really quite self-explanatory and includes the patient's healthcare needs, health problems, and relevant conditions. This can include social considerations as well as medical, and should list all members of the patient's care team, including family and community assistance. The next documentation requirement focuses on goal setting with the patient. Developing these in conjunction with the patient ensures that the plan is personalised to them. The team involved can create some templates or prompts to ensure they ask the best questions of the patient to achieve personalised goals, and practices can reach out to us for templates to assist with this. Goals can also be developed around planning for future care, visits and billable items. For example, the team may like to consider discussing the benefits of that patient attending for a seasonal influenza vaccination, meaning at the time of that visit, a 10997 could also be billed. Example prompts for ensuring the patient understands their management plan and the purpose of it could include asking, do you know what your health conditions are? What is the biggest issue that you feel is affecting the condition or making it worse? What would you be able to do if this was controlled? Is it stopping them from doing anything? What is something you can start today to get you closer to your goal? It is important to note that your goal for the patient might not be the same as what the patient has identified that they want. For example, the patient could state, they want to lose 10 kilos so they can fit into a size 12 dress for my daughter's wedding in September. Whereas our goal that could possibly result in a similar outcome may be based around the lifestyle changes the patient is making regarding their chronic disease management. Our team can assist with education and resources on the creation of SMART goals for your practice team. The next point on this slide around documenting actions required to be taken by the patient can assist in making them accountable towards the process of good chronic disease management. Can include discussions around lifestyle changes, medication compliance, education, and accountability with self-management of measuring and recording disease indicators such as blood sugar levels or blood pressure, and ensuring engagement with other members of the team or services. The list of treatments and services the patient is likely to need will assist in creating a team care arrangement, may assist a patient with any funding applications, and can make case conferencing and chronic disease management review easier down the track. It is also a good opportunity to be able to explain to patients how the other members of the multidisciplinary team fit in and can be helpful in managing their condition. The last 2 points on documenting arrangements are fairly self-explanatory, but should be discussed with the patient for scheduling purposes. So the next slide is looking at case conferencing, which has been described by practices I've worked with as the icing on the cake in terms of chronic disease management. As we're fairly time limited, I won't go into all the eligibility criteria, but we can offer to send out a draft policy detailing all of this that you can use as a template for your practice if you'd like to look into this further. Or we're happy to arrange a meeting to discuss how this might work for your particular practice. However, I would like to point out some of the benefits of case conferencing and why it might be of use for your practice in managing chronic diseases. When a patient has a chronic disease, chances are that they need additional support and more people involved in their care team. Case conferencing is a really good way to collaboratively plan out the patient's journey, being able to take into consideration all services and opportunities that may come with specialist knowledge, and to have everybody on the same page for the patient, making communication clearer, as well as it being easier for the patient to understand and to achieve their goals. Most practitioners will probably find that they're already discussing patients' cases or seeking another opinion or advice from a colleague in the lunchroom or the corridor. So it makes sense to formalise the process to make it more clear for everyone involved and to obtain the MBS benefits. Blocking out time to do case conferencing and creating processes and workflows around this becomes more time efficient when compared with the administrative burden of phoning or emailing other members of the care team backwards and forwards trying to work together. Case conferencing can also serve as an opportunity to create and strengthen relationships with other practitioners. It can assist with referral pathways and in gaining knowledge of other services. It is also a great opportunity to educate each other. The idea of organising the process can appear daunting, but one consideration that might make it easier is that it can actually be done with video or telephone participation from external allied health. And services are popping up now that are specifying that they're happy to participate in GP case conferencing, such as Diabetes Connect, although currently this is only available in country WA. So in conclusion, implementing evidence-based practices in chronic disease management involves a commitment to continuous quality improvement, in effective leadership and collaboration of the whole multidisciplinary team. Continuous education and staying updated with the latest guidelines for chronic disease management is crucial, particularly at the moment, given that we're expecting changes to be announced. We would always recommend consistently checking in with MBS Online, as this is updated frequently. Integrating technology into practice, such as the Primary Sense tool discussed by Kathy, to identify patients that would benefit from a chronic disease management plan enhances care delivery. And emphasising patient-centred care improves patient outcomes. Finally, regularly evaluating and adapting practices ensures ongoing improvement in the quality of care provided. As always, at WAFA, we are always delighted when you reach out and we can come out and assist with the excellent work that we know you're already doing. We're happy to provide one-on-one support for your practice around your chronic disease management processes or even help with setting them up. Please do reach out. Our team contact email is on this slide, or when you receive the slide deck later, you'll have additional access to our direct booking links for your specific area.
Thank you everyone for your valuable input today. As you can see on the screen, we've got some of our upcoming events in this webinar series. So on the 18th of June, we'll be looking at practice nurse accreditation. And then after that, the third webinar on the 10th of September will be focusing on older adults within this space. And on the 19th of November, we'll be looking at men's and women's health. So these will also be in the post-event email that gets sent out to you guys. So you can also lock it in your calendars as well. I'm just going to go to the next slide and just thank everyone for your time in attending our webinar today on behalf of all the team here at WAFA, and thank you again to our QI coaches for your presentations as well. On the screen, I have put a QR code on there, and that is for our customer voice feedback survey. So if you did find today beneficial and you would like to provide some feedback on the content or the facilitation, anything like that, we definitely value feedback. It just helps us to build our training events moving forward. So if you could take the time to fill that out, that would be great. And I will also just add a link into the chat for those of you who may already be doing this on your phones today, so you can access that. And we'll leave it on the screen for a little bit. But on behalf of myself and the team here at WAFA, we just want to thank you for joining us this afternoon, and we hope that you have an enjoyable day. Take care. Bye-bye.